Good morning, everyone. Today morning, we are going to demonstrate a case of Ostial LAD CTO. So, coming to the clinical history of the case, it was a 25 years old male presented with acute infeval STEMI 1 month ago, with a background history of strong family history of premature CAD, and his early function was or EF was on 50%. He was in sinus rhythm, and he was de novo diagnosed with diabetes, uh, hyperlipidemia, and 1 year history of hypertension. So his echo was showing RWM in RCA territory. So we have taken him for a angiogram. Angiogram on the right side should showing it was PLVB 100% thrombotic occlusion. So that was the culprit vessel. And left check showed Ostial LAD 100% occlusion. And it was short segment CTO, and it was filling retrogradely from the right coronary artery, but there are not significant, no good interventional collaterals. You can see in the LAO caudal view, there is short segment Ostial LAD, and there's some homocoronary collaterals filling the LAD from the LMCS stem. So initially we did the primary angioplasty to the PLVB. So it was uneventful and showing good result. This was the procedure, and this was the final result, showing good TIMI3 flow. So after this, we staged the procedure for LAD CTO. So patient came back of 1 month for the staged LAD CTO. And coming to the JCTO score, it was a ambiguous cap, and score gets a score of 1. It was length was short segment and with no significant angulation. Calcium, it was not a retro lesion. So JCTO score comes to be 1. Now we'll move on to live case.
So, okay, this is a case of Ostial LAD CTO, ambiguous entry. In other words, the lesion length is short and no angulation or calcium. So, the only challenge is ambiguity in entry. So what we planned is please check. So we planned an IVUS guided, wiring. So, okay. IVUS guided cap puncture. So we took a 8 French guide in view of taking IVUS as well as crusade catheter on one wire. But if it doesn't work out, then I'll switch to 7 French with a fine cross. Okay. Okay. Come to caudal. The guide in an IVUS guided entry should be, stable. So if it is hanging in aorta, it won't give you adequate support. So it has to be stable. So, yeah. Okay, small check. Okay. So anyway, we wired with a hanging guide, but then we pushed the guide inside to get some support. All right. Okay. So we can still further, move. Okay. All right. I think now it is sitting in LAD. Nicely, there is no pressure damp. So guide sitting in LAD is very crucial. So without that, we don't get enough support for anti-grade cap puncture, especially when we are using stiff wires. Okay, first step is localization of cap. Keep seeing ECG somebody. Okay, this is 8 French guide. All right, okay. No, I'm just going further down. Okay. Yeah, record. నాకు ఇక్కడ play again. So there is at 3 o'clock actually. Just go back, 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 back. No, yeah, just play from here. You just keep watching at 3 o'clock. Yes, 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 yes. That 3 o'clock thing. Just go back. You can just give a longitudinal rotate. Bring that arrow to 3 o'clock. Yeah, yeah, yeah. No, that's all, that's all, that's all, that's all. Now you can see there at 12 o'clock. Just go back, little back. Yeah, play. Right. So, okay. So now what I'll do, I'll take, yeah, give me crusade, please. Yeah. Okay. So give me crusade and then give me Gaia. So now I went deep into the branch and I'm pulling transducer back, bubble, inject. So, and I'll keep, yeah. So this is already in LM. Okay. So that is now at, yeah, 12 o'clock. You can see that's a cap. Okay. Right. So, right. So that, yeah. That's just gone in. Yeah. Just give me crusade, please. Yeah. So this is a crusade on the same wire. And now you can see, yeah. So I'm just proximal to the transducer. Yeah. Give me Gaia 2, please. So one advantage having crusade there is no need to give a secondary bend to your CTO wire. Yeah, so let's see how it works. If it doesn't work, then you can stop IVUS for a while. Yeah, right. No wire is there. So you can see now, actually crusade is occluding your entry point. So I have to pull crusade back. Then I'll try to, yeah, all right. You can see that is at 12 o'clock. Okay, that is at 12 o'clock. And I think crusade is going to give us tough time here. Let me try. Is it? So I think it doesn't work this way. So I have to take. Okay, okay, stop. So why is not orienting? So we'll give a secondary band. So it's in the direction, right? So but I'll just check. Yeah, it's perfectly sitting on the block. Okay, okay. Oh, okay. No. You're recording. Okay. So you can see now it is perfect. Perfect. Okay, just come to epicortal, please. Or a coral. So our entry is perfect. Only thing is when you gave a secondary band, it prevents your further progression because of uh, Go to epicranial or elocranial. Okay. Wait, wait. Oh, shit. Hey, go to electoral, please. That's an entry which we created. Okay, that's where again we have to go. Mhm. I need another one. Give me Hornet 14, please. Hornet 10 or 14. See, this wire is so subtle, it's not going um, after entering proximal cap. So now we'll go with a stiff wire, enter in, and then we'll de-escalate wire back to Gaia. Hornet 10, 14, please. So IVUS, please. Yeah. Yeah, I think that's the position. Yes. Yes. Okay. So we can, yeah, we can just recheck now. So now you can see it is exactly going to the cap. Okay. Yeah. Right. So it's, yes. Okay. Okay. Now just go to crane. We can just do a, right. Okay. We can just do one recording here. I'll just do a recording here. Auto will just stop. Yeah, now you can see. Stop. Yeah. So you can see that. See, that's a clear position, we achieved. So yeah, we can also take one shot here just to make sure, we are in line with the distal LAD. Yeah. Yeah. Okay. Yes. We are in line with distal LAD. Right. Perfect. So yeah, I think it is perfect. The chat. Yeah. Yeah. Okay. So now, since I'm okay with my wire position in IVUS, so it's time we have to pull out our IVUS and, give me Corsair 130. So we'll take out IVUS catheter and we'll take Corsair into LAD, then we'll de-escalate wire and, we'll reach. So the crucial point here is, removing Corsair IVUS. Keep a tapper balloon all ready. So, okay, go to yellow coral then. Okay, so what we have to understand, yeah, wait. So what I'll do now, I'll just pull a wire, my workhorse wire back. Now IVUS catheter is out of this wire. Now again, I'll send the wire, okay, down. Now you can see the IVUS catheter is out of the wire. Now I can pull IVUS without disturbing. Without disturbing my crusade and the wire. Okay, done. So that is very crucial here. You shouldn't lose your wire position, because if you lose again, you end up in doing same thing again and again. Give me tapper balloon, please. So now what we'll do is, so we'll put a tapper and remove crusade, and then we'll go to Corsair, advance Corsair. Right. So now I'm pulling crusade back. So without losing wire position, that is a key. Yes, please. Give me a Corsair, please. Okay, remove trapper. Wait. Remove trapper. So the advantage with Corsair is it gives you some leverage and rotating and pushing, which you won't get with other microcatheters. I think now we are into LED. All right. Okay, just go to epicranial. Yeah. Give me Gaia 2. So we are de-escalating wire back to Gaia 2. That is very crucial at this moment. Want to go subintimal again. Oh, just check. No, wait. So it just slipped into the vessel, it seems. So yeah, just check. Wow, that's great. Okay, so I think that's an advantage. Nice. Okay. So we already mentioned. See here, the challenge is okay. So give me workhorse were right. Yeah. Or Renato, better Renato. So that's an advantage. So with the de-escalation, so escalation, de-escalation, had we continued with the same harnett, it would have gone, suboptimal. So since we switched to Gaia, so it's a 1 mm band, so naturally its tendency to stay in lumen will be very high. So yeah, I can see now. So see, that's a big LED, huge LED. Okay, so it's going into all branches, which confirms your okay, perfect. Okay, Trap, please. Okay, right. Negative. Oh, no, wait. Yeah. So just give me IVUS, another IVUS. Do a complete IVUS from LCX just to have a look at any, flaps created or, no, yeah, records. Yeah. So it's perfect. So your anti-grade wire is perfect, and we have not lifted any flaps in LM. Yeah, that's what happens, when you use Harnet or Gaia. Sometimes, if you are not precisive, you might lift, flaps. Stop. Just show us again. Yeah, give us a 2.5 balloon, please. Now go back, go back, go back. Yeah, keep a bookmark. Yeah, next, play, bookmark, play, bookmark. We can see now the wire appeared at 3 o'clock and it is looking at the center of the vessel. Play, go back, little go back, little go back, little go back, go. Yeah, put another bookmark. Yeah, now play, book, stop. Yeah, bookmark. So you can see the wire is exactly in the center. So if you see all the bookmarks from beginning, 1, 2, 3, 4, show me 1, 2, 3, 4, all bookmarks, only bookmarks. Yeah, yeah, B3. So now it's appeared, the wire is appeared in the center of the lumen, right? Next bookmark. Yeah, again, it's center next. Again, so now you can see it is in the center of the proximal cap. So okay, now you can see in longitudinal view. Longitudinal view, you can show longitudinal. Yeah, that's okay. Yeah. So that's a wire, which entered into LED. You can, yeah, I can just rotate and show. Yes. Okay. Yeah. Dilate, please. Yeah. Yeah. Negative. Dilate. 18, 20, 20, 28. Hmm. Negative. Dilate. 28. Hmm. It really doesn't matter, you can even start from LM. I think there's no need to be so. Okay. Okay. Now give me IVUS, IVUS from LID, please. So we're doing IVUS from LID just to decide on stunting strategy. Yeah. Done. All right. Our proximal record. Yeah, either record. Mm. Next. Is that right? Okay, next. Yeah, this is all the block. Okay. Play. No, no, play. Ostium. Stop. Go back. Just go back. Yeah, I could better. Bookmark. Yeah. Yeah. No, it makes sense, you'll cover into LM. Bookmark here. Yeah. Yeah. Bookmark here. Okay. Okay, what is the length from B2 to B4? Hmm. Since there is only one branch, I think one OEM, so we can just treat this from LM to LAD. B2 to B6, 20, right? So 3, 20, 23, stunt ready button. B1, B1 to B6. What is the block area at B6? Hmm. ఇంకా తగ్గించి ఇంకా ఏమని all right, okay, done. I think so. Give us 320. Yeah. And what is the pot size LMCA? No, B6. I think it's 3.5. Okay, we need a 3 stunt and 3.5 balloon for post dilatation, please. Okay. Mhm. So we decided to go across LM bifurcation into LMCA because block is extending into LM, and there is only one OM here, so it's quite safer to stunt from LM to LAD. So as ostium of that ramus intermediates, just go back to the first first IVUS, please. Yeah, come forward. No, go back, 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 back. Yeah, ఇక్కడ bookmark pattern. Yeah, what's the area? So there is no block in the ostial ramus, and lumen area is 5.5. So that's quite good. It won't compromise. So nothing to worry about it. Yeah. 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 Dalit. 3.58. Yeah. Dalit. Dalit again. Yeah. Dalit again. Negative. Yeah. Okay. 3.58, please. Yeah, dilate. So we're doing part with 3.5, 8 balloon, 16, 18, 20, please. 22. What is the size of 22, 3.5? Negative. Negative. Yeah, dilate. Yeah, negative. Negative. Just give me sunburst. Just make me understand what I covered. Yeah, 3 balloon, please. Yeah, I think we covered everything. Okay. 3 balloon, please. 3 NC, please. Huh? NC. 8 or 12, no problem. Yeah, 18. Negative. Sunburst. 22. Negative. 24. 26. Negative. Yeah, 26. Negative. Out. Yeah, give us final IVUS, please. Yeah, give NTZ. We dilated with the 3 up to 26 atmospheres and 3.5, nearly 22 atmospheres for proximal optimization. Now we'll do final IVUS followed by, and we'll come out. Yeah, record. Hmm. Yeah, I think this is a stun started. Nicely expanded. Hmm. 2 up to ostium. Huh? Hmm. Okay, right. So I think US, yeah, out, out, out. Yeah, just go to, yeah, చేసేయండి. Let's see. We'll explain I was once all are done. I think this is final result. Good result. Okay. Give NTZ, please. Go to LFR, please. That's fine. Oh, are you caudal? Okay. Out. You can see this is a distal reference, which is 7 mm square. So with a 2.9 to 3 mm, diameter, luminal diameter, you can see all the proximal stent areas, or more than this. You can see all minuses. Now you can show us B3. Yeah, B3. Right, 8.1 mm square. Ostial LAD, please. Yeah, I can see 7.4 mm square. Next, LMCA 10 mm squared. So it's a good uh, IVUS result and good angiographic result too. You can see this is a good angiographic result too. So yeah, there might be some pinching of the ramus, but we're not really bothered about it. So it is flowing nicely. So just leave it. Don't do anything about it. And we all know that in bifurcation, provisional stunting is the best strategy, which gives you better long-term outcomes. Okay, so fine. So you want any final view? Yeah, give orocranial, any closer device. All right, okay, fine. So it's perfect. Okay, ouch. So this is a good case of Ostial LAD CTO. The only challenge here was ambiguous cap. So it was not clear where the cap was. So we used IVUS to localize the cap, and then did puncture under live IVUS with the Crusade catheter. Later, we removed IVUS catheter, and then Crusade followed by advancement of Corsair, and then wide de-escalation back to Gaia 2, and with which we could complete. So thank you all. Thank you, Dr. Damodar, Sister Annapurna, Dr. Daya,